Good morning. Good morning. Thank you for coming in so early. It's nice to see some familiar faces here, faces that are not paediatric intensivists as well. So that always makes me very anxious. I'm David Tingay from Melbourne, Australia. We have about 45 minutes to tackle the question that Peter posed for me, which was to provide some practical respiratory physiologists. Oh, sorry, that shouldn't be for the neonatologist. It should be for the intensivist. My mistake. I am a neonatologist. I will be talking about mechanical ventilation and the application of physiology during mechanical ventilation. So I should just say I do have some conflicts of interest in terms of relationships with mechanical ventilator manufacturers. I'm also going to make a disclosure statement that I am a neonatologist. I'm meant to be talking about respiratory physiology to paediatric intensivists. And as you probably gathered yesterday afternoon, neonatologists don't know much about respiratory physiology when it comes to the bigger people intensivists. Marcelo Amato's presentation very much reinforced that we are dabbling while you are excelling. So what I'm going to try to do is to highlight some of the similarities and differences between a baby and a child, and to give you as a paediatric intensivist some insight into the strange cognitive thinking that goes on inside a neonatologist's mind when a baby is in a NICU. Because I suspect, at least in Australia, for the paediatric intensivists, they find what we do somewhat perplexing at times. The first thing I want to remind paediatric intensivists is not all babies in the NICU are preterm. So we deal with a variety of pathology. And here we may have 4 not uncommon conditions that are managed in the NICU. So we have the lung condition which saturates neonatal respiratory management, HMD, or respiratory distress syndrome related to primary surfactant deficiency due to prematurity. Not all preterm babies are born with small lungs because their lungs are collapsing. Babies can be born with lungs which have not grown, so we also manage pulmonary hyperplasia. This is an area which I particularly am interested in myself, and I think an area that we need to always remember. A small lung may not be a surfactant deficient lung, it may just be a small lung, and that needs a different approach to our understanding. Unfortunately, one thing neonatologists have historically been very good at for more than 50 years is creating lung injury. Whenever we think we've solved one type of lung injury, we invent a new type. So we've gone from barotrauma to volutrauma to barotrauma to volutrauma to atelectotrauma to volutrauma to rheotrauma to ergotrauma. So we just keep moving between them. And many of our babies, unfortunately, end up developing manifestations of chronic lung disease, which is a very complicated condition and can present with lots of different types of interstitial, vascular and alveolar changes. And then we manage babies who are born at term with normally developed lungs, who present with acute complications of either their fetal or post-fetal life. And MAS is probably the archetypical condition. I try not to think of the diagnosis as much, but think about how is that lung condition presenting mechanically in the baby's lung. And this, I think, is one of my take-home messages I'm wanting to put across to you, which is don't worry too much about the diagnosis. Think about the physiological manifestations of it, and then we can start talking with a common language. If you have RDS, then you predominantly have atelectasis as your problem. You have a lung that's poorly compliant and it wants to collapse. If you have pulmonary hyperplasia, you have hyperplasia. The compliance is not a huge problem. They have lower lung compliance, but it's not at the same magnitude of HMD, and in many cases I think the biggest risk factor for this group of babies is us, because we try to manage them as if their lungs are not hyperplastic. If you have evolving BPD, in many cases you have a problem of altered lung compliance, altered elastance and chest wall status, but airway changes and an issue with resistance and hence gas trapping. Very different presentation, different approach to ventilation. And when you have MAS or similar conditions like ARDS, you often have a mixed lung condition, and you as the clinician need to decide whether the problem is one of predominantly compliance, resistance, or a mixture of the two. What this means is that there can never be a single universal mode of ventilation that will be optimal for every baby. So we need to think about how we're going to get the right treatment for the right baby. I'm going to make just a little summary here. We all talk about what lung protective ventilation is. We all say we're lung protective. I think we should all declare at the start what our definition of lung protective ventilation is. Mine is the application of respiratory support that optimises oxygenation and ventilation. That's why we've got them on respiratory support. There's a problem there, whilst attempting to minimise potentially injurious events. We can never make the injurious events totally go away. We have to minimise them. In the interest of time, I'm not going to talk about two tenets of respiratory support in neonatal intensive care. One is don't intubate. If you don't have to intubate, don't intubate. Keep a baby off a ventilator is the best way of preventing them getting positive pressure-related lung injury. And where possible, allow permissive hypercapnia. We know that that is safe, that is effective, and it is one of the good tools in terms of minimising pressure, volume and other exposure to lung injury, and also it gets you extubated quickly. So I won't go into them in details, but take them as the take-home messages of NICU respiratory law. Why do we need to understand respiratory physiology? Because in the NICU, it's like every other aspect of intensive care. Our machines are designed to be confusing. They have lots of different modes. We, interestingly, don't have the same language in how we talk about modes across critical care craft groups. We don't often even have the same language about how we talk about ventilator modes within NICU settings. So I might use assist control, and I know in Melbourne another NICU with the same, almost with the same ventilator, their machine says SIPPV, and another one will say PTV. They're all essentially the same thing, but the ventilator says that they might be different. They're not. And I think when it comes down to this discussion around all the different modes, we need to remember that most of the evidence is not about one mode being better than another. It's about how we apply that mode. So you need to pick the mode you think is right for your patient and then apply it in the right way. In a neonatal ventilator, all of our modes, essentially, there are some exceptions on some ventilators, are time-cycled pressure-limited ventilation or flow-cycled pressure-limited ventilation. And I think that's really important. You remember if you're using volume control and other things, that essentially when we talk about volume targeting, which I'll talk about in a minute, we're essentially talking still about time cycle pressure limited ventilation. We're just allowing the ventilator to be involved in how it changes pressure to deliver volume. What do the lungs do? Neonatal lungs are no different from any other lung. They are an organ of motion. They are designed to oxygenate, to ventilate, clear CO2, that's alveolar minute ventilation, and diffuse and perfuse. This is a morning of revision, not new topics. It's too early to be doing new things. So if you're all looking at me going, why are we doing like first year medicine stuff? I think it's worth going back to basics. And I'm trying to demonstrate the similarities. We can use our ventilator to control oxygenation and ventilation, and you can see here the ways we can do that are exactly the same in an adult, a paediatric and a neonatal lung. The concepts are the same. What we need to do is to give the lung enough time to inflate and enough time to deflate and apply only enough pressure to make it move as much as you need it and not make it move more than you need it. So let's talk a little bit about pressure. And I think most of you have probably seen these videos before. They've been around for a long time. These are, for those of you who haven't, these are alveolar under electron microscope of adult piglets with ARDS, but the concept is the same in neonates. You could imagine this is a preterm baby with RDS. And these videos really nicely illustrate the core concept of how positive pressure ventilation helps the lung move. So hopefully it'll play. And no, that would be a no, so I apologise. They worked when upstairs. I'll walk through them without the wonder of video. So here you can see a nest of 3 little alveoli. you can see here 2 more little alveoli. In the video, you would see that when they're being applied with a PEEP of 5 and an inflating pressure, these alveoli are opening and closing. But in expiration here, you can see this alveolar is collapsed. These alveoli are actually maintaining end expiratory volume at the end of positive inflation pressure. The PEEP is turned up to 10. Now you can see these 2 alveoli are acting in the same way in terms of their end expiratory pressure. So this really nicely visually demonstrates, if you could have seen it, that it is the PIP that is inflating the lung. It's creating the tidal volume, and it's the PEP that maintains it. And we need to apply enough PEP to maintain end expiratory lung volume because it makes the next inflation easier. And that's essentially how we are managing atelectatic lung disease in the NICU. No different from how you heard Professor Amato talk about how they're considering management of ARDS in adults. We need to provide enough PEEP to overcome atelectasis and not so much PEEP that we impede lung mechanics, which you can see here from this very elegant study that was performed by Peter Dargaville, Peter Rimmers and Ines Ferrich, who is here in the audience, where they took a series of neonatal piglets with an ARDS type model of surfactant deficiency. They were on a set delta P, and I apologise for those of you here on Thursday morning because we talked about this, Wednesday morning, we talked about this then, from a PEEP of 0 up to a PEEP of 25 and then down again. And you can see their pressure volume loops as they went from a PEEP that was insufficient and was creating atelectasis through to the opening pressure of the lung, the lower inflection point of the lung, and then up through the zone of recruitment on the pressure volume limb. You can see that the lung compliance is improving. The regionality of lung compliance is improving. This was with EIT. So you can see 3 different gravity-dependent parts of the lung. You can see at this point that lung compliance is very different. And this is really important in HMD or RDS. We have profound surfactant deficiency. We do have a heterogeneous lung disease. And I keep trying to remind my trainees that whilst we tell everyone that respiratory distress syndrome is a homogeneous disease, it is homogeneous because the whole lung has the same disease. But if we misapply our ventilation, it is a heterogeneous problem. So here we have a problem of atelectasis due to surfactant deficiency. You can see that the compliance curves are very different in different parts of the lung when the lung is atelectatic. So in the most dependent part of the lung, you have a non-compliant lung, but in the least dependent part of the lung, you have a lung which actually is taking quite a lot of ventilation. So when we set our 4, 5, 6, 7, 8 mil per kilo of tidal ventilation, that's all going to one part of the lung and not the other. So in this situation, and we've shown this in the animal lab, whilst we are worried about atelectotrauma, we're actually causing volutrauma in some parts of the lung. As Ines and colleagues took the PEEP up, you can see that the heterogeneity of recruitment becomes more homogeneous. You can see that lung compliance improves, but then you get to a point where your PEEP is too high and you start causing overdistension. We can see now we start to lose lung compliance and we start to lose tidal volume, but now we start to generate, but that loss is universal. So we've now got a homogeneous lung which is behaving badly. Before we had a heterogeneous lung which was behaving badly. If we then decrease our PEEP, we can map the deflation limb, and we can see now we maintain a homogeneity of ventilation and we get an improvement in lung compliance. So what we're wanting to do in our babies who have atelectatic lung disease is try to apply a respiratory strategy which delivers a PEEP which maintains recruitment and applies ventilation here on the deflation limb. That's pretty simple. That clearly makes sense. Translating it is really hard. And we don't have the data that you have in from adult ARDS or the data that we have from paediatric trials as to how we can do that in babies, because we're limited due to the situation we have created for ourselves, which is a good one for the babies, in that we are encouraging breathing, so it's much harder to measure lung mechanics, and we use non-cuffed tubes, which means on invasive ventilation we can't really trust the measurements that we're getting from our ventilators. And as Andreas Schibler, who's not here today, not here at this meeting this year, once said to me as a paediatric intensivist, he said, I go to these meetings and hear all you neonatologists yabbering about, oh my God, the baby's in 30% oxygen. And I never see, when I see a bad ARDS, I just want them in less than 80% oxygen. So we don't have the same ability to use oxygen as a target change that that you have in adult ARDS and so forth. So we have a lack of bedside tools to help know what our lung volume is, and we have a lack of ability to actually know we're reliably making the change we want during PEEP. So we have a problem there, and that's why I think you'll see in the neonatal community we use PEEP a lot more cautiously than in adult and paediatric medicine. It does, and you see a variation of practice which is not evidence-based. So I've demonstrated, I hope, that the PEEP is really important in atelectatic lung disease in the neonates, but I cannot give you any guidance as to what the right PEEP should be. And what I would suggest is you do what many of us think we need to do, which is actually stay at the bedside and watch the patient and learn. Moreover, we tend to use non-invasive ventilation a lot, as all ICU has done. That's a good thing. The same concepts apply, and we and others, and Risha, who's also here in the audience, has shown this, have been able to show that on non-invasive ventilation, changing PEEP or CPAP levels will change lung volume, and that we can recruit and de-recruit a lung using CPAP, but we have, again, more problems with how we understand it. And I just wanted to make you, just highlight again, that when we're thinking about PEEP levels in babies, we are generally encouraging them to breathe as well. So we need to think not just, and we're using non-invasive ventilation, so we need to think about not just the PEEP level as its role on FRC, but what role is that having with work of breathing, comfort and efficiency of ventilation, which again, I think we don't have good bedside tools for, but we need to consider it. And there will be a sweet spot between a PEEP or CPAP level on non-invasive, which encourages atelectasis, and will therefore increase work of breathing, and one which encourages over-dissension and the same clinical manifestation of work of breathing. And as I showed on Wednesday, we have a number of bedside studies which have shown that work of breathing is quite important during non-invasive ventilation for babies, and that there is a relationship between at least very low CPAP levels and increased work of breathing. What we don't know is there an impeded relationship on work of breathing with very high CPAP levels, because we just haven't done those studies yet. This is a really nice study which was published a couple of years ago, comparing a CPAP, a traditional mode of delivering CPAP and positive pressure ventilation in the delivery room to preterm babies, versus a device which is quite novel and designed to give a low imposed work of breathing, the RPAP system, essentially giving the same positive pressure strategy, but a different way of delivering non-invasive ventilation, with one designed to take out the imposed work of breathing. And you could see in this study that there was a significant improvement in outcomes which we could at least infer may be related to the impact of work of breathing on the baby's transition at birth, that is the need for intubation or death in the first, within the first 30 minutes of birth. So one would expect that if you gave the same pressure during non-invasive ventilation, but a baby needed more intubation, then if all other things have been equal, it was related to the higher work of breathing the baby had during that approach. And you'll see, just like, that's why you'll see that most neonatal CPAP devices use very short prongs, binasal prongs. They're designed to decrease resistance and make more comfortable for the patient. What about delivering tidal inflations if a patient's intubated? We have lots of ways of synchronising. We know quite clearly from this very old study now from the US that if we allow patients to have unsupported synchronised breaths, they actually will do worse. So SIMV in acute lung disease without supporting every inflation is going to result in less efficient ventilation, longer duration of ventilation, and worse lung mechanics than if you support every breath. And indeed, in this study, they quite nicely showed, it wasn't a large study, but they quite nicely showed that if every inflation had at least some degree of pressure support, minimum of 3 centimetres of water in their study, there was improved elastic unloading, and you'd expect improved outcomes. So I think from that position, I would strongly advocate that in a neonate who has an altered chest wall compared to an adult and a child, and an inability often to maintain their tidal motion as well as a child, that we should support every breath when they're intubated with synchronisation and not support some breaths. So most of us now would use or would advocate assist control, pressure support, SIPPV or PTV, depending on your mode of ventilator, rather than just isolated SIMV alone. And you can see that here with this waveform of a baby, where you can see on SIMV, we've got a supported breath. You can see the improvement in the tidal volume, the flow wave, and then you can see an unsupported breath. That baby's doing all the work there. The tidal volume is less efficient. And you compare that then to when pressure support at least is added on to those breaths, so there's an SIMV breath and a pressure supported breath, you can suddenly see that at least the baby's flow wave is a little better and that tidal volume is slightly better too. As I highlighted on Wednesday, we need to use different trigger settings, often compared to older, bigger people. Our babies are smaller. Our ventilators use flow as a method of triggering. You should never, in my view, put a baby on a ventilator with a method of triggering where the trigger is hidden in the ventilator. It needs to be as close to the patient as possible. These patients are smaller. They're going to generate less flow when they take a breath in, so you need to have a trigger which is as close to that patient as possible so that you can minimise the imposed dead space of the circuit. And you're going to use a trigger setting which is going to be much lower than you would use on children, because again, and I showed this the other day, you can see that the flow, the peak flow that's occurring here is actually only 3 litres per minute. So we don't want trigger of our ventilator to be too late. We want the baby to get the most support during positive pressure ventilation, so we want a trigger that reflects the flow patterns of our baby, and that generally means flow levels of 0.2 to 0.6 litres per minute. And I've just talked about that. How do we support tidal inflations? Well, how do we decide what tidal inflation to give? Traditionally, we've set a PIP, an inflating pressure. Again, remembering we're using time cycle pressure limited ventilation. There's no plateau pressure per se. The plateau pressure and the delta and the PIP are essentially the same pressure. We will then hope that that is the right PIP to exchange gas, and we would then hope that the tidal volume is one where we are applying tidal ventilation safely. We know that tidal volume is equal to compliance times delta P. In a lung disease which is rapidly changing, we're going to see that in that situation, if we have a constant delta P and our lung compliance changes, our tidal volume will change, and there's the potential that the patient could get a tidal inflation which is very high or a tidal inflation which is very low, and take the baby out of the zone which we think is safe for tidal ventilation. If we then add in that the patient might be breathing as well and adding in their own component to tidal volume, the delta P we're applying may be insufficient if the patient is fully apneic, or appropriate, or it may actually be far more excessive when the patient takes their own breath. So most of us have moved to using volume targeted ventilation. Again, to remind you that these are time cycle pressure limited or flow cycle pressure limited ventilators. So we're not actually controlling absolutely the amount of volume we're giving. We're telling the ventilator what volume we would like it to give, and then the ventilator looks at the PIP, to the delta P that it gave, and tries to adjust the next PIP based on what it thinks will be needed for the tidal volume we've told it to do. And by activating that mode, we have seen good outcomes. Neonatal meta-analysis of neonatal respiratory modalities is notoriously depressing. If you look at most of our big trials or meta-analysis of different modalities, even synchronisation in meta-analysis does not look favourable. Well, it looks favourable, but not as good as it should. It doesn't reduce BPD in meta-analysis, it reduces the duration of ventilation. That's probably because of the trial design and the ventilators at the time they were done, but you would expect that there would be more benefit in meta-analysis, and it's also got to do a little bit about meta-analysis itself. But standing out from all of these sort of large trial failures that we've essentially had to a certain degree is volume targeted ventilation, which on meta-analysis reduces BPD significantly, a number needed to treat of 8, which compared to what Haresh was showing yesterday is actually quite positive. But this is in comparison to other intubated patients, not to non-invasive, and a reduction in all of our major complications related to prematurity and a shorter duration of ventilation. So, as I sort of said on the session on Wednesday, I believe quite firmly now that what happened when I was a fellow, which was, oh, should we turn volume targeted on, is now the wrong question. Our question should not be, should I use it? Our question should be, why should I not be using it? Our default must always be to try to trigger and synchronise every inflation on a ventilated patient and to use volume-targeted ventilation on every patient and then only not use it when we can justify it can't be used. The question is how to set tidal volume. The ventilator doesn't know, the baby knows, and unfortunately we need to try to know as well. These were not trials of different tidal volumes. They were trials of a modality that modulated tidal volume. And as, again, I'm reiterating some of the things we talked about on Wednesday morning in the workshop, the volume that leaves the ventilator is not the volume needed to support gas exchange. Gas exchange occurs at the alveolar level, and we need to maintain an appropriate alveolar volume to support CO2 clearance, which is related to our rate. And to do that appropriately, we need to ensure that our tidal volume leaving the ventilator is sufficiently large to overcome the dead space that the patient has and deliver sufficient tidal volume into the alveolus to support minute ventilation. Which means we need to have some idea about, firstly, what will the dead space be, some idea about what the actual tidal volume, the alveolar volume you need to support minute ventilation will be, and some idea about what then your set tidal volume will be. And this is a nice summary table which is available in the archives, which demonstrates that dead space changes over time. So here you can see the newly born preterm baby or the term baby has a dead space which is essentially normal, so 4 to 5 mil per kilo, maybe 6 mil per kilo in the babies who are very small because they have a relatively large dead space compared to alveolar surface area, is going to be appropriate as a starting minimum tidal volume for these babies. But as the baby develops chronic lung disease or has other pathologies which might result in a larger dead space in their respiratory system, you need to increase your tidal volume appropriately. And as Ines showed, the tidal volume we deliver is related to our lung volume and our PEP. So setting 4 mil per kilo is, and you think that's going to be lung protective, will only be lung protective if you have a lung which is aerated. If it's an atelectatic lung, it's still not lung protective. So the first part of setting good tidal volume targeted ventilation is to ensure that you have the correct PEEP that optimises lung compliance. It'll give you a lower tidal volume. Then you need to set the right tidal volume for your minute ventilation and your dead space, and you now need to think about the TI and the TE. So again, compared to PICU, we tend to use lower tidal volumes than PICU, and I hope I provide some rationale for that. And we tend to use I times and E times and rates, which are quite different from PICU. So I'll just briefly explain why we do that. And we do it for exactly the same reason you set your I time and your E time, is we need to give enough time for the lung to fully inflate to get that volume in and fully deflate to get that volume out. And that's related to the time constant, which is compliance times resistance. So if we think about a neonate as opposed to an adult or an older child, a normal healthy term baby has pretty normal lungs. So they have a normal compliance. Neonatologists are not clever people. So it's really easy to measure normal compliance is about 1 mil per kilo per centimetre of water. One's about as far as we can go. So we've got here a 3 kilo baby with a compliance of 1. Resistance is pretty normal and will be low. So our time constant is about 0.12 of a second. We need to make sure our I time is at least 3 time constants and ideally 5 time constants. So now you can see that we need an I time of about 0.4 to 0.6 of a second. So I'm trying to provide some rationale as to why we use these weird I times in the NICU compared to PICU, at least in Australia. If you have parenchymal lung disease like HMD, we've got an impairment of compliance but normal resistance, so our time constant is less. And these very preterm babies with very severe RDS have very short time constants. I would not set my I time at 0.2 of a second, but if you look at these babies in pressure support, sometimes they are doing it by themselves. But you're going to need a shorter I time than you would for a normal lung. You can now see why we use these very short I times. You can also see that we're now starting to move towards a lung protective approach. We've got more time to get more breaths in a minute. We're using short I times so we can get more inflations in, which means we can use a faster rate. And if we can use a faster rate, we can get CO2 clearance with a lower tidal volume. So you can see the evolution of the fast rate, low tidal volume, adequate PEEP for recruitment strategy starts to come together physiologically in these very preterm babies as well. And it is indeed physiological and allows us to do that. But if we turn it the other way and have a predominant airway disease problem like bronchiolitis in an infant, we have a resistance problem and generally only a mild impairment of compliance. Now you see we need to have a longer I time to allow enough inflation and deflation. And of course that means we need a longer expiratory time and therefore a shorter, less rate per minute, and we will need to apply a higher tidal volume to maintain CO2 clearance. I've got like 5 minutes, so I'm going to walk through high frequency because that only needs 5 minutes. It's pretty easy. And neonatologists love high frequency. No one else loves high frequency. As Martin said yesterday, we're the last bastions of high frequency. Some of us really love high frequency. Despite our love of high frequency, we don't have good trial evidence. And we have tried really hard in randomised trials to make high frequency good for preterm babies. We've got almost 4,000 babies who've been in the individual patient meta-analysis. And that shows a slight benefit. And again, as someone who likes high frequency, I would say, oh yes, it definitely reduces BPD by discharge. If you don't like high frequency, you say it's not good enough to change practice. So and you can see that there is no difference in the most recent meta-analysis on air leak, IVH, and both types of IVH, despite what some people say. So we've got better at it because the original trial showed that we were causing air leak and IVH. What we need to go is to look in more detail and learn from this meta-analysis. A lot of you could learn from it. So firstly, the meta-analysis clearly shows that we must use a high lung volume strategy to apply high frequency successfully. The question is, what is a high lung volume strategy? It's a statement, not a guideline. And then we need to actually ask ourselves, in these trials where we got different results, what was the control group? The control group got conventional mechanical ventilation. Many of these trials are old. We've recently just reviewed these, and hopefully this paper will come out soon. And we actually focused less on the high frequency strategies, but the conventional strategies. And you can see that when you break down the sort of things we do in the NICU now, permissive hypercapnia, synchronisation, volume targeted ventilation, and then we made a composite of a modern lung protective strategy, only 6 out of the 19 large trials that were involved in the meta-analysis met that definition, and it was mainly because they used permissive hypercapnia. So most of these trials didn't have lung protective conventional strategies. So what I'm saying to you here is in most patients, you don't have to use the oscillator, you just have to ventilate them well. If you're good at conventional, use conventional. If you're good at high frequency, use high frequency. Most of them used a high lung volume strategy on the oscillator which applied a mean airway pressure above conventional. Many of them would wean FO2 before weaning mean, which are part of the high volume strategy. Only 5 used an alveolar recruitment manoeuvre. Achieving lung recruitment is easy on the oscillator when you have atelectasis. So because you're giving a set mean airway pressure, the tidal volume changes are not high, and essentially just moving up end expiratory lung volume. And as Martijn Medema and Anton van Taam have shown that when you do an open lung manoeuvre where you take the mean airway pressure from a low mean airway pressure up to high mean airway pressure and then down again, you can clearly see a relationship between mean airway pressure and oxygenation. And we've shown, and Martijn has shown, that that relationship marries the volume relationship. So it's telling us in the oscillated patients at least, we can use oxygenation as a proxy of lung volume, which we don't have the ability to easily do during conventional ventilation. So this concept of open lung ventilation, where you start at a mean airway pressure, if you're poorly oxygenated, you will increase your mean airway pressure in a stepwise fashion until you get an improvement in oxygenation or prove you can't get an improvement in oxygenation, and then you decrease your mean airway pressure to exploit hysteresis to maintain lung recruitment at a lower mean airway pressure with more uniform ventilation and aeration in the lung has been applied. I think we all focus on the more recent, which are now not that recent studies, but I just want to highlight, it was Peter Rimmensberger that first did this in babies. A long time ago, showed that an open lung approach could be applied and was effective in preterm babies. We spent some time on term babies, and Anton has spent a lot of time looking at how to do this well in preterm babies and developed a really nice approach to it, which most of us follow. And there are still people looking at this, and there's some recent studies that have done it. One of the practical questions for paediatric intensivists is how long do we wait in a baby when we make a change in something on the oscillator compared to a child? Martijn's group, Anton's group in the Netherlands, showed that in preterm babies of active HMD, you only need to wait 1 to 2 minutes after changing mean airway pressure before you see a new stabilised lung volume. So it's a very quick process, which makes sense. These babies have poorly compliant atelectatic lungs. Things move quickly if you provide enough pressure to move them. We showed that in babies, term babies, much more with a pathology in keeping with ARDS or PARDS, that the time needed to change, to wait for a new lung volume after a mean airway pressure change was much longer, and indeed in some babies at more than 10 minutes. So if I'm doing a mean airway pressure change on an oscillated big baby with an ARDS type picture, I would wait at least 5 minutes and generally 10 or more, particularly if you have a lot of resistive change. When shouldn't you give too much pressure to the lung with the oscillator? Anything where there's not atelectasis. So if you have pulmonary hyperplasia, CDH, primary pulmonary hypertension, don't try to give them a lot of mean airway pressure and try to recruit the lung. The lung's not recruitable, it's not so because it's not atelectatic, it's actually injurious if you do that. How do we set the delta P on an oscillator? And how do we clear CO2? CO2 clearance on high frequency is frequency times VT squared. If you want to spend the rest of the day being really bored, unless you're into mathematics, go read the original works that describe why it's VT squared. I always tell my fellows it's just all magic, but it's true. And the tidal volume that you're delivering during high frequency is the area under the oscillatory curve, which means we now have 2 ways to change it that are interrelated, which is different from conventional. In conventional ventilation, tidal volume and rate are totally independent, but on high frequency, if we change our delta P, we will increase our stroke volume and area under the curve, but likewise, if we change our frequency, we are changing tidal volume as well. And that's really important to remember. In high frequency, tidal ventilation is interrelated with your rate. It is not independent. So how do we do that? Well, we need to think about what frequency to apply. The other mysteries of high frequency is that unlike conventional, the rate setting we apply is affected not just by the disease, it's affected by the baby's size, it's affected by the ET size, which we, I think, saw on Wednesday at the workshop, and it's affected by what you perceive the injury risk will be. Because you can see if we drop our frequency very, very low, we could give very large tidal volumes. And we've heard a few times at this meeting during a discussion of high frequency, we are all recording tidal volumes that are above dead space. We are all recording, whether it's a child or a baby, we frequently record tidal volumes being measured during a high frequency of 4, 5, 6 mil per kilo, which are not what we think we're doing. So just be aware that too low a frequency can give large volumes. So this is my non-evidence-based approach to applying frequency in neonates on the oscillator. If they have preterm lung disease, they are small, they have poor compliance, they have short inspiratory time, they have short time constants. We're very worried about exposing them to too high tidal volumes. We want a faster frequency. So I would be starting at 12 or above, dependent somewhat on the oscillator. If they've got early PIE, they may not have surfactant deficiency anymore, but we still have many of the same problems. And what we are seeing in early PIE is volutrauma in evolution. So we need to minimise that evolution. We want to arrest it. So the best way to do that is continue using a very high frequency, so we minimise volume approach. So I continue with a high frequency, maybe even go up a little bit higher. If they have very cystic gas trapping conditions, that won't work anymore. The damage has been done. And here we need to give enough time to account for the increased resistance and poor elasticity, and enough time for the lung to empty during high frequency expiration, and also acknowledge these babies are rarely the same size. They're often a lot bigger. So I would use a lower frequency. People used to talk about going to 6 and below. I get very anxious applying frequencies less than 7, and I would potentially even move this up a little bit. In our unit, if we get this condition and we're not able to clear CO2 with frequencies of 7 to 8, we would now put them on the jet ventilator. Term baby with RDS has surfactant deficiency. The same mechanics and lung physiology applies, but they're a bigger baby, so they need a lower frequency. So you can see I'm setting a frequency range which is a little bit lower than the preterm baby. Most of us would tend to use 10 because in Western culture 10's a number that we all seem to focus on. It's a nice number. I don't think it's got any science behind it. I don't think I've ever seen a baby on a frequency of 11, I don't know. I might do that when I go back to Australia, disrupt the status quo. If they have an aspiration syndrome and involving sort of severe, any of the aspiration syndromes, we generally have poor compliance, but we may have severe gas trapping. So here it gets more fun, and they're generally really big babies, many of them. So if they've got predominantly a surfactant deficient problem with their MAS, I would tend to use a very higher end of the range for frequency. But if they've got resistance as their main problem, then I tend to go down with a frequency to sort of at 7 or 8 and play around. Just be aware that in these kids, if they're not working at a frequency of 10 and you've got gas trapping, go down and they often get more stable. We see that a lot in our ECMO referrals, that they've just gone too high with their frequency. CDH is hyperplasia in a bigger baby. Lung injury is our problem there. I would be very cautious about using low frequencies in those babies. We now have volume-targeted ventilation in high frequency. If you think it's complicated in conventional, which I don't think it is, but some people think it is, it's really complicated in high frequency, and we have no evidence around its utility. It's all observational studies. The reason I think it's complicated, I quite like it as a modality. What worries me is that we're all used to doing conventional with volume-targeted ventilation, and it is not the same modality because, as I showed you, frequency and tidal volume are interrelated on the oscillator, not dependent from each other. And we have patients breathing, and we have a much more complicated interaction between the ventilator, the settings, and the condition of the baby. So this is not my table, but it's a table that Jane Pillow has produced and allowing me to share here. And we've got a paper coming out on this soon, which with a section on how do you decide what tidal volume to set if you're going to use volume-targeted ventilation with high frequency. I quite like Jane's approach. She says actually we want to target a DCO2, and that these are approximate ranges of DCO2 that we should target. Unfortunately, these are not displayed on your ventilator because it's milled squared there, and you don't get that on a ventilator, so it's a slightly different calculation. So she's generated a table as a starting range and differentiated it between babies who are breathing and not breathing, and therefore having a different contribution to their tidal ventilation and gas exchange, and has highlighted, which I've not seen in other guidelines before, that the frequency you set will affect your tidal volume, and therefore you will use a different strategy. And I just want to point out here, if you've got a baby on volume-targeted ventilation of a frequency of 10 and you change them to a frequency of 7.5, and at 10 you had normal gas exchange, when you go to 7.5, that tidal volume may not be right for gas exchange anymore due to that interrelationship, so you'll need to change it. So in summary, if you've got a baby in the NICU, try to let them breathe. They're better at breathing than we are at making them breathing. Try not to intubate them as possible. Allow them to have permissive hypocapnia. Try to support every inflation. And that the optimal strategies that we use in the NICU are not different from the PICU. We're aiming to understand how the lung works, how the lung moves, and trying to individualise our therapy to what we think the pathology is. And I simplify it. There's atelectasis, there's hyperplasia, there's normal lungs, there's gas trapping, they're mixed conditions. That's literally all there is. And give enough PEEP to prevent atelectasis if you have atelectasis, not too much PEEP if you don't have atelectasis, and give the lung enough time to inflate and deflate and support minute ventilation. So I've gone just to time and I apologise for that. So thank you for your time. If there are a couple of, maybe it looks like there's people at the door, so I think Peter's there, which really worries me. So we might move on to the next session and I'll be around at coffee if anyone wants to ask any questions.